uh, we will be now taking the inputs of Dr. Anil Kumar, sir, who is heading the National Organ Transplant Organization. And he's spearheading this diseased organ transplant as well as other organ transplant programs in India through his organization and the sub organizations of ROTO, SOTO. So, sir, as I'm studying the Gujarat SOTO, I would also like your valuable inputs on at the national level what you would be doing to further improve diseased organ transplant.
Yeah. So main challenges that we face in the deceased organ donor transplant, one is brainstem death declaration in the hospitals. That is not happening. Because there are people, patients who are lying in the ICU. They should be identified. Those who are brainstem dead, they should be identified. Somebody should check them. The doctors who are doing duty in the ICUs, they should basically suspect if this person is likely to be brainstem dead, and then get them certified by the 4 doctors, so that brainstem death patient's identification and declaration, that needs to be improved. And that not only need to be improved, that should be monitored by the hospital authorities, because that monitoring through an audit system is very important, because we expect certain percentage of patients who are in the ICU to be brainstem dead, and if that is not happening against a benchmark or against a parameter, then it should be questioned and they should be identified. Then second, we need to have a coordination with the trauma units, because now in our country, like last year 1.68 lakh people have died in the accidents, and these are all potential donors, because their brains are usually injured. These are young healthy individuals, and we should try to save their lives. Our pre-hospital care and our bringing them to the nearest emergencies within the golden hour is very important. And that when they are in the ICUs on a support system, and if we are not able to save them life, or they unfortunately become brainstem dead, then it is we should these are the great potential donors whose organs are healthy and it could be harvested. The third provision which law has already given, that organ retrieval centers, that law has permitted registration of non-transplant organ retrieval centers, and so we are now pushing for establishing a organ retrieval center in every medical college wherever the MBBS is being taught, whether in government or in private. And these organ retrieval centers should also be set up in every trauma center, wherever trauma care is being given. So, because every medical college has the minimum facilities which for harvesting the organs, because you require just an ICU and an operation theater and a brainstem death certifying committee. And if neuro experts are not available, then anesthetist and intensivist can certify in place of the neuro experts, and it identified transplant coordinator, which could be any staff of the hospital itself. So not much infrastructure is required for organ retrieval center, so that every medical college should be capable of doing organ retrieval. Even the district hospitals, which are big district hospitals, they can also carry out these organ retrievals. So at least once the donation number improves, and these donated organs could be transported to the facilities where the organ transplantation is taking place. So basically it is a type of a hub and spoke model, where there is a organ transplant center connected to various donation centers. And another intervention which is very important, the fourth point, would be to establish a government multi-organ transplant center, at least one in every state, so that this hub and spoke which we are envisaging, where the organ retrieval centers the organs are being brought, and it should function. Another important intervention could be to have dedicated transplant units in the departments which are concerned departments for every like for a kidney transplant. The concerned departments are Department of Surgery, Department of Urology, Department of Nephrology. So if we have one of the unit is dedicated for transplant, and the unit faculty is also trained in transplant, only those faculty which are trained in transplant are recruited in that unit. So we can have by rotation of the residents in that unit. These residents could also be trained, the PG residents, and training capacity of the of these medical colleges where these dedicated transplant units are there could be enhanced. And this can be a possibility in the existing centers wherever such units can be set up, wherever such departments which are related to the transplant are available. These dedicated transplant units will definitely help in pushing the organ donation as well as transplantation in those centers. So we are also now moving towards donation, improving the donation after cardiac death. Only right now only few centers in the country are practicing, but there is a scope. All over the internationally it is recognized that donation after cardiac death can be done. At least kidney, liver, they can be harvested, and these can be and because that cardiac death is more acceptable as a death even among all stakeholders, public as well as the medical stakeholders. So that also needs to be enhanced and improved. Then certain institutions, because law requires that you need to have a dedicated transplant coordinator who encourages and who counsels the family for organ donation and transplantation. So transplant coordinator should be made available in these centers wherever donation and transplantation can happen, so that they routinely are involved in these type of exercise of identifying the brainstem dead donors. So again, one more thing that we advocate, that all centers which are trying to be organ donation center or transplant center should regularly conduct medical education programs in their hospital to sensitize all the types of doctors, paramedical staff, nursing staff. So that should be well trained in towards the organ donation and transplantation. One of the usually identified problem is another problem, which is because the brainstem death as of now is not listed as a mode of death under the Registration of Birth and Death Act, and it is not mentioned on the medical certificate or death certificate that is being used by the hospitals. So if brainstem, there could be a uniform declaration of the death, could be a provision can be added in the, either by amending the Registration of Birth and Death Act or by having a separate law on this. So where a brainstem death patients are also included in the definition of death and they are registered like that. So that would also help the medical fraternity, because some of them have doubt that if the donation is not happening, then they are not able to withdraw the support in these because as per them, this law, the regulation is not very clear whether they can withdraw the support system in the situation of a brainstem death or not, because the heart is kept functional with the support of a ventilator and other support fluids, etc., inotropes, etc. So that is also a that uniform declaration of the death needs to be brought in through regulations.